70% said that if there is involvement of the serosa of rectum above the peritoneal reflection or there is a mesenteric involvement, then the rectum should be removed. And if rectosigmoid resection has been done, in which cases should you give a covering stoma? So the covering stoma should be given if the anastomosis is below the peritoneal reflection, when neoadjuvant bevacizumab has been administered, and you know this is becoming commoner day by day, and if the patient's factors, multiple factors, like patient has low hemoglobin, low albumin, or it has been an extensively long surgery, you may think, and the bowel gets edematous, or the bowel condition you feel is not okay. These are physician-made decisions, but at least in these three cases, you should be giving a covering stoma. Now, we would differ slightly with Sir on regional lymphadenectomy. So, normally, how do you assess lymph nodes? You do a preoperative investigation, normally a CT. And what are the CT criteria of involved lymph nodes? They are rounded, there is loss of architecture, then there can be an internal necrosis. So these are criteria. Just an enlarged node doesn't mean an involved node. The active nodes will be elongated. On the other hand, involved nodes will be rounded. So we should basically assess the lymph nodes based on preoperative imaging and intra-op assessment by opening the peritoneum and palpating the lymph nodes. If you try to palpate the lymph node through the peritoneum, only 10% of the lymph nodes can be actually filled. So you need to open the peritoneum of the pelvic spaces, you need to open the peritoneum of the retroperitoneal region and then palpate the lymph nodes. Only then, if on preoperative imaging and on intra-op assessment, you find that there is no lymph node involvement, can you actually avoid lymphadenectomy? Then this is based on the Lions trial. So systematic lymphadenectomy should be done only if lymph nodes are enlarged or involved on preoperative imaging. And this is actually the NCCN as well as the European guidelines also say the same. So that we don't have to do a systematic lymphadenectomy if they are not involved. And where they are involved, the bulky lymph nodes should be removed. Lesser omentum, should it be routinely removed? There was no consensus on this. Every time you are removing the falciform ligament, I don't know if you could see, Sir was demonstrating it brilliantly, the hepatic bridge has to be divided. Because most of the time the disease lies at the root, and if you don't divide the hepatic bridge, you will miss out that disease. So I will skip this. Which regions should be addressed during interval cytoreduction? Now, this is a question which is routinely asked. What should you remove in an interval setting? Because now the disease has resolved. You don't know where the original disease lied. So what we are doing is removing all previously involved sites in stage 3. That means if the patient has stage 3 disease to begin with, had peritoneal disease, had lymph node disease, confined to the abdomen, even if it has resolved after chemotherapy, you should remove that. On the other hand, if the disease was stage 4, already outside the abdomen, then in that case, you remove only the residual disease. Yeah, I'll just finish it. Yeah. Okay. So, secondary cytoreduction. Okay. Secondary cytoreduction should be done for patients who have a platinum-sensitive relapse and the disease is oligometastatic. Okay. Should secondary CRS be performed if the patient has ascites? Yes. If it is a low volume ascites and the disease is completely resectable, you should. Okay. And what are the criteria? You know, what is the desktop criteria? What are the 3 important trials in secondary cytoreduction? First is the desktop trial, second is the GOG 213 trial, and the third is the Chinese trial. Okay. So here in the Chinese trial, they have used the I model score, and for the desktop, they have used the AGO score. There is also an MSKC score. You can use a combination of these scores, but ultimately it's your clinical and radiological judgment. Okay. So let me just see. There is no upper age limit or lower age limit for HIPEC. Should HIPEC be performed in primary cytoreduction? No, not outside a clinical trial. With secondary cytoreduction, you can consider if it is a platinum-sensitive relapse. With bevacizumab, we can give HIPEC provided we have kept a gap of 6 weeks. Okay. HIPEC is known to increase the rates of anastomotic leaks, but there was no strong consensus on that. It is also known to increase the bone problems and fistulas, or we achieved a consensus on that. Okay. So we have already discussed this. Yeah, that's it. So how many of you use Kelm score? How many of you are aware of Kelm score? So Kelm score is basically a score where we see the CA125 decline with neoadjuvant chemotherapy. There is a Kelm score calculator which you can use. If it is more than 1, that means if the response is good, you will achieve, there is a higher likelihood that you will achieve optimal cytoreduction. If it is less than 1, then suboptimal cytoreduction is likely. So this is basically, you can go through the paper. It's an exhaustive paper published in Indian Journal of Surgical Oncology. Thank you very much.
Thank you so much, ma'am.
Yes, sir.
The staging is the most important. That is the basic component of this very gynecological staging in early stage also. You use the staging.
Yes, sir.
So, somebody in advanced ovarian cancer, where the 70 to 80% involvement is there, 70 to 80%. Even we are talking about the lion tail. See, the both arms are there in the lion tail. Those arms, they are not dissected the lymph node and they are not dissected.
56%, yes, sir.
And even they have shown this 55.7% the node positivity is there. Even my series I have seen that is 60% lymph node positivity is there after neoadjuvant chemotherapy.
Right.
So my question, when you talk about the CC0, so you are leaving behind the disease and how you can claim, suppose you cannot after NCD you know that is the node shape is not actually optimum. And how we can say this thing without removal of that node? How can you say?
Yes, sir. I'll answer that question. Sir, CC0 is no visible cross disease. We cannot predict which portion will have microscopic disease or not. That is number one. Second, the Lion trial, it found that in cases where they did a systematic lymphadenectomy, they found microscopic disease in the lymph nodes in 56% patients, but that did not translate into improvement in survival because all the patients got chemotherapy and the chemotherapy took care of the microscopic disease. So in a CA ovary, there might be microscopic disease in visceral peritoneum, in many other areas. Is normal, you can find disease, isolated disease in central tendon. So, sir, the answer is that in spite of removing microscopic disease, more to the morbidity without improving the survival. That is why these days, even the guidelines have said that you should not do a systematic.
So that is, I know the guideline sort of thing is there. I don't know because that is the argument kind of thing is there. You see this. Suppose you are living behind the disease, So that is true. Even if the patient come to know about the nodes are there, they don't know what is that exactly the thing, but nodes are remaining thing. But you don't feel that psychological burden is there also apart from this.
A lot of normal looking stuff in ovaries. Say visceral peritoneum, which is looking normal, we are leaving it. We are not doing a complete this thing. We can find microscopic disease anywhere. The idea is that all these patients will undergo chemotherapy, and nowadays, if they are HRD positive or BRCA positive, they will also receive targeted therapy. So it's not translating into improvement in survival. And many times the lymphocyst formation, if there is infection, it may lead to initiation of adjuvant.
That is actually they have shown this 12% complication is there compared to the non-lymphatic 8%. Even mortality.
To achieve an improvement in survival, that is my question. If we are not improving this, and the other thing is, many times when the disease they present with recurrent retroperitoneal and peritoneal disease most of the time. It's not that isolated retroperitoneal recurrence cannot happen, but most of the times it is associated with peritoneal.
Health that way or not?
It's already stage 3. I mean, in an advanced. See, I totally agree. Stage 1 and stage 2, you should do a systematic lymphadenectomy, no doubt about it. But in stage 3 and 4, the patient already knows.
Thank you so much, ma'am. Thank you so much, sir. Dr. Swapnil has to be somewhere, so I would request Professor H.S. Shukla sir, Tarun sir, and Meena sir to please felicitate sir with bouquet, memento, and a shawl as a mark of our gratitude and respect. Can we have a big round of applause for sir for such an insightful lecture? Thank you, everyone. Moving on to our next lecture, we have Dr. Rakesh Garg. Sir will be talking about anesthesia during HIPEC. I request Dr. Ankit to formally introduce her.
Our next speaker reminds us that oncology is not just about surgery, but also about comprehensive and holistic patient management. It is my privilege to introduce Dr. Rakesh Garg, sir. He is professor at IMS, New Delhi, specializing in onco-anesthesiology, critical care, pain, and palliative medicine. A former editor-in-chief of Indian Journal of Anesthesia with over 250 publications, his contribution to research and patient care is truly commendable. Sir, we are honored to have you with us. May I request Dr. Rakesh Garg, sir, to kindly take the stage.
Thank you so much. Special thanks to Madam for inviting from the Department of Surgical Oncology, and thanks to Professor Mere also, the team that we work at AIMS. And I was fortunate enough to meet all the dignitaries from the Department of Surgical Oncology, and great privilege to meet one of the, I can say, the fatherly figure in this field, Shukla sir, who has been pioneer in this field, contributing extensively for the growth of our specialty. So probably I'm just the odd man out, except Amrita joins me from the anesthesia department. But I'll just take you through some of the things when the surgery meets the aid. So I don't know, the surgeons are always hot or in an enthusiastic mood. But yes, sometimes that enthusiasm when translated in the form of hyper is always good for the patient. And Madam has mentioned nicely that what are those indications where we can look for. Having said that, it's always good. As anesthesiologists, we are always concerned the patient is hypothermia, the patient will not get extubated. So don't open up the abdomen too much. Do it from a small incision. Go ahead with laparoscopic surgery. You can always bounce back and say that now, see, we are making hypothermia, so enjoy the anesthesia and the things well. But remember that when we give these drugs of hypothermia, along with the drug which has its own toxicity, these toxicities are further exaggerated during the surgical process. And what I have learned from my teachers is a very basic dictum which is applicable for anesthesiologist and perioperative physician is maintain the physiology. A simple word, a simple sentence, maintain the physiology. But I think we have spent more than 2 decades to understand what is physiology and how to maintain it. And that's what the perioperative medicine is. And once we understand it, the things becomes very simple. So I'll just take you through some of them, and I hope you will be able to understand it. So this is CRS HIPEC is just not a surgical procedure. So don't think as you do Whipple's procedure or as you do thoracotomies, it will be as same process, except that you are putting up some fluid through a machine at high temperature of 42 degrees for 60 minutes, nothing different. But you need to understand, it is something like a physiological stress test, right? If you know, some of you who have sent for PACs pre-operatively, a patient of CAD, we ask them to do something called cardiopulmonary exercise testing, right? This is for us to understand whether patient can undergo that stressful surgery or not. So that test is as simple as that. So this is almost same, because now we are taking this patient to the extremes of pathology. Anything which goes wrong with the patient at this point of time, he will have some morbidity and maybe mortality. Patient can go into liver failure, patient can go into renal failure, patient can go into cardiac failure, patient can go into respiratory failure, patient can go into multiple metabolic failure. This term is important when you say CRS hypec. It's just not the organ failure, but metabolic failure is one of the important aspects that will lead to increased morbidity and mortality. And that is what we are doing behind the screen to manage these patients that will take care of us. So I will not go through this because you already know it. You do the procedures, indications you have already seen. The PCI score we talk about. We talk about how it is done. So this is just basic things. So I'm skipping it because you already know that. But what is need to understand is that when we give these drugs, why this is happening? Because the drug that you give to these patients, they will have some barrier. So whatever you give the hyperthermic drugs, so the resection that you have done for this patient, they become a raw surface area, isn't it? You will do peritoniectomy, ombectomy, sometimes you will strip up something, you will try to remove the macroscopic tumors, and those are the raw surface area. When these are raw surface area, right, and these are sometimes a little oozing coming from those areas. Now, now you add on to them, the residual tumor or the microscopic tumors, that's what the purpose for HIPEC is. But also these all things are going into the systemic circulation. And that's the reason why these patients will have a lot of metabolic changes. If you see the ABG picture, there will be severe metabolic acidosis, their lactate levels will start rising, there will be onset of acute kidney injury, the kidney will be trying to shut down, the liver will try to become hyperactive initially, but now it will start dysfunctioning, not only with increased bilirubin, but with also increased liver enzymes. The cardiac markers will start rising, the cardiomyopathy will start happening, lung will become more diffusive, it will become having leaky capillaries, fluid will start accumulating there, and so on and so forth. So this whole mechanism is just not giving the circulatory fluid at 42 degrees Celsius with a chemotherapeutic agent into the abdomen, but actually it goes through the body circulation. And that is what we are looking for, and that's what the specific procedure that we are looking for. And this is how the cell death happens. You know it very well, so I may not be going to detail, but that is how the hypothermic was. But then we are talking about the local tissue damage. Same thing is happening to the healthy tissues also. So that's why the toxicity that happens is more of an issue, and we should be looking for. Now, I'll skip this thing. This is primarily, I thought some of my anesthesiologist colleagues will be there. So this is technique that we have learned. So I'll not go through these techniques. I can skip the slides. These are all things. Now, what we are concerned is, this is what as a team we work in. So when we do the cases with laser ray, we take a combined decision, right? And what are those combined decisions we're talking about? The first most important is the assessment and optimization. How many of you have heard a term called rehabilitation? Just you heard the term? You follow them up? Partly. There is a thing called partly. Right? So this is the key of the success. Right? Now, just tell me if how many of you run the marathon? None of you. How many of sir runs it? Right. Sir, when you run the marathon, you get invited to some Bombay marathon, full marathon. Do you just go there to a flight and run for the marathon, or do you prepare some days and weeks before? You would try. And how much does it take for you, even your marathon runner, When you go for marathon, how much time you spend to acclimatize yourself to run the marathon?
We are playing football.
Right. So this means, this is, I said, CRS HIPEC is a physiological stress test, right? He is running marathon for long. Even if you want to run a marathon, he is practicing daily. So when you get a CRS HIPEC done, this is what rehabilitation is. So you have to prepare the patient to tolerate the stress that is going to happen in the perioperative period of CRS HIPEC. And I think this is the success. So I'll tell you the success key of Major Ray also. I can disclose that key here. Because when we say rehabilitation, surgeons are usually very pro for कि CRS करेंगे, we will do BH and PSO and ये करेंगे. But who will tell that इसको एक hemodynamic भी start कर दीजिए, walk for 30 minutes every day. And I think he's a busy clinic, so he has made a stamp, right? And mutually agreed upon, which was part of anesthesiologist. She also agrees, and that stamp is put on the day one when the patient comes to him in the PSM day. And that is 8 to 10 points, which is part of rehabilitation. So this means as resident, whenever the patient, I'm not talking about CRS HIPEC, this is the key to success of any major surgical procedure. I know that you are doing MCS surgical oncology. You are more focused on dissection, anastomosis, and suturing and cutting. But also, there is something called preparing these patients. So whenever you get a chance on day one, and this is key success for oncology surgery specifically, start rehabilitation. And there are certain key things. High protein diet, start them on iron supplements, just ask them to walk whatever they can. If they are walking 15 minutes, say 20 minutes, next time 30 minutes. If they are able to fly, go up one flight of stairs, next time say just go 1.5 flight of stairs. After 2 weeks, just a 2 flight of stairs. And these are all part of rehabilitation. So this is what you need to do. This is the most important aspect. If you can do it, most of the time nothing will happen in property. Patient will come very nicely. Whatever the PCIs, whatever the resection you do, whether you are doing some diaphragmatic stripping, you are doing collateral lymph node, you are doing almost pelvic exfiltration, nothing will happen to these patients because they are able to run for 42 kilometers for a full marathon because they have practiced it. So whatever extensive surgery you do, even if you have say 2-3 liters of blood loss, they have an habituation of tolerating them, right? So this is the important aspect, and obviously the post-operative care. Equally good is the post-operative care. What if you have done a good surgery, do 2 resection anastomosis, right? Ureteric reimplantation, and the patient is on 3 inotrops, right? I will be happy that BP is 120 by 80. Things are okay. But what is happening to your anastomotic sites? What is happening to them? To vasoconstriction. And in oncology settings, sometimes you don't get a good margin. Sometimes they are under stress a little bit, your anastomotic sites. Now, if they are not getting proper perfusion, and because they are 3 liters of blood loss, and simultaneously you are on 2 or 3 inotrops, think how that anastomotic site is weeping. Neither getting blood, not getting oxygen. So what will be the outcome? Right? So whatever you do, whatever type of anastomosis you do, whatever staplers you use, whatever suturing you do, things are already compromised. So this means the post-operative care is equally more important. And sometimes it's important, you ask a sister to give 500 ml of fluid, and she does it in 5 minutes, and you know that when you do a CRS HIPEC, the things are inflamed. When they're inflamed, the capillaries are leaky, right? Not the other tissues. If you give half liter of fluid and you have cut some organ, it is leaky, where the fluid will go? On those areas, if fluid collects, what happens to the perfusion further on? Decrease. So what is increasing? The surgical complication. So that's why this type of surgical procedures are more of a teamwork. I'll be happy that I am able to maintain a urine output of 100 ml. I'll be happy that there is no tachycardia. I'll be happy that blood pressure is 110 by 70. But what is actually happening to your surgical outcome? Right? This is a teamwork that we need to understand, which improves the patient's outcome, because we have to think the physiological aspect of each thing, small things. And that is what, when we say small things, these small things, वो बोलते हैं ना कि बूंद बूंद से सागर भरता है. So these are all small things which will increase the outcome of these patients that we should take care of, right? So this is what we do when we have the concerns. So when we manage these patients, there will be timings that we'll be talking about, right? So for us, the timing will be the baseline part. We will prepare them. And usually when you do a surgery, we divide it into 4 aspects. Each has a different connotation for us. When we start the procedure, there will be certain things. When you start your the resection, there will be something different for us. When we start reconstruction, something different for us. And when we do a post-operative care, there is something for us. As a surgeon, it is reduction, cycle reduction, it is hypec, closure, and shifting the patient to ICU. But for maintaining the physiology, each phase is very different. That is important for us to understand, right? So when I say cytoreductive surgery, now this is the area where patient will be exposed. There may be a blood loss, and there will be a chance of hypothermia. Now this whole the area where the oozing starts happening, it will lead to more bleeding, and the outcome will decrease. This is the term when we want that the patient's euthermia should be maintained. And that's why it's equally important, even in today morning, those who are in the operating room, I was very much concerned if the patient enters the operating room, the temperature management starts from that point itself, no confusion. So don't think patients are coming in the operating room with just kurta pajama. There are no undergarments that we usually use, so they are exposed to a OT temperature of 24 degrees Celsius. Sometime I will, when my residents do it, I will just say simply, right? Switch on your AC at your home at 24 degrees Celsius for 6 to 8 hours, and then lie in the bed with hands like this on the OT table. Just wait how you feel in next 1 hour. Can you do it? Those who don't understand it, I will ask them to just do it at their home just once. You will just realize that how intense body physiology changes. And that's why just remember when the patient is shifted or wheeled inside the operating room, the management of temperature starts from there itself. Don't uncover the patient unnecessarily. Cover them with blanket. There is something called preemptive temperature management, and this is very, very important. You should do it. Similarly, when you're doing cytoreduction, try to use warm fluids wherever possible. Try to cover them up. If you see drapes are laden with blood, try to remove them up. And that is what we are doing temperature management, because remember, hypothermia and hyperthermia both leads to coagulopathy, right? And this patient will have both the things. Now, this is an important point. Sometimes I have कि अभी जब हम हाइपेक देंगे तो टेम्परेचर बढ़ेगा, तो अभी टेम्परेचर गिरने देते हैं, राइट? सो दिस इज समथिंग एज कि आप दोनों साइड का उसका डिसएडवांटेज. हाइपोथर्मिया के अपने साइड इफेक्ट्स हैं, दे आर नॉट न्यूट्रलाइज्ड बाय हाइपरथर्मिया लेटर ऑन. हाइपरथर्मिया के अपने साइड इफेक्ट्स हैं, एंड बोथ द साइड इफेक्ट्स आर एडेड ऑन. So that's why always remember that as a surgical colleague, as an anesthesiologist, we have to take care of this process. Hypec, obviously, temperature will start rising, but remember when you do a hypec, you know that those who are involved into renal transplant, they understand that the temperature of kidney is very, very sensitive to the external environment. If they are hypothermic, the temperature, the kidney can go into renal shutdown very fast. Since in cytoreduction, anybody have heard of called swimming a full? राइट? एक फूल होता है, उसको टच करते हो तो बंद हो जाता है वो. किडनी भी कुछ ऐसा ही होता है. See those who do kidney transplant, they don't handle the kidney too much. But when you're doing cytoreduction, you will be handling them up, right? And when they are exposed to temperature fluctuation, they further shut down. When you expose them to a cytotoxic drug like cisplatin, they shut down. And that's why we have to be very cautious by giving fluids, by maintaining temperature, so that those renal shutdown is not happening. Reconstruction, I just told you that what we are concerned with, and as a team, how we'll be able to manage. And post-operative, I also discuss a bit of it, and how we can manage that, right? This is what we do for pre-operative assessment. You can also add on into some of these aspects. Equally, performance status we usually see, and that is part we try to improve them with rehabilitation aspect. chemotherapy, they will always would have received some cycles of chemotherapy, especially for COPD patients. Look for, so this is how we test them, right? So this is a CPAT machine where we assess the cardiorespiratory results. It's like a treadmill, and we want these patients to, at least if they're running for 15 minutes, ask them to run for 20 minutes. If they're walking for 15 minutes, ask them to walk for 20 minutes and gradually increase it. And then you try to look for whatever the drugs they are taking, and obviously the other amount of counseling. Always remember, I was just looking the pre-operative chart that has been filled by Department of Surgical Oncology. There was a drug, benzodiazepine. Right, so delete that column of now. I can request the Department of Surgical Oncology, don't give benzodiazepines to your patients for this major surgical procedure, because it causes a lot of problem. Hemodynamics is something. So try to omit benzodiazepines at pre-operative until unless they are cardiac patients, they are too anxious, they are not aware of it. Otherwise, they causes delirium, they causes cognitive dysfunction, they cause delayed awakening, and they also have effect on the hemodynamics. So that's why we don't want to do it, and the counseling becomes important in these aspects, right? Other concern that we look for is the respiratory function. Many of these patients will have arthritis. Do you agree? Some of them will have reactive pleural effusion also. When we say ascites and pleural effusion, that will lead to the collapse of the lungs, right? Because there will be pressure on the diaphragm. If there is a mass in the abdomen, because of the tumor itself, again it will split the diaphragm up and there will be basal atelectasis. This means that the lung is not functioning optimally. It's not functioning physiologically. And you need to open them up. And this is what I said, when a patient comes to you, that's why in those parameters we say start them on incentive spirometry, start them on deep breathing exercises. Nowadays people are very fond of yoga. If they say I want to do pranayama, just do it, because we want the lungs to be opened up. This is important. Because if you do a subdiaphragmatic splinting, if you're working on the upper abdominal surgeries, 8-hour surgeries, there is bound to happen dorsal atelectasis of the lungs, right? There is bound to happen basal atelectasis of the lung. Sometimes when you do a hypec, there will be reactionary pleural effusion, which happens to some of these patients. So if you can open up the lung preoperatively, the outcome becomes good. The oxygen requirement goes down, and the patient outcome will be much better. That's why these are the concerns that we look for. The cardiovascular morbidity, these patients at times may be having some cardiomyopathy, primarily because they have received certain chemotherapeutic agent which are cardiotoxic. So try to evaluate for them, and that's why we say that the last cycle of chemotherapy and surgery should have a gap of around 4 to 6 weeks, which taken conventionally, because it spontaneously tries to regress back. Pain management is another important, which we, as anesthesiologists, please do manage them. It's very, very important to give them pain management. We do follow up our patients for 5 to 7 days till they are completely healed up. Give them good pain management. You need to mobilize them the next day. You need to make them walk as soon as possible. The function becomes better, chances of DVT decreases, and the lung function also increases. And pain management needs to be continued. But remember, these patients, when you give them hypec, try to avoid NSAIDs. So don't try to give them preoperatively, intraoperatively, or postoperatively. So your prescription should not have NSAIDs, because NSAIDs, any insult to the kidney, can be further precipitated even by a single dose of diclofenac. So try to avoid them. The drug of choice is usually will be regional loss, and you can start them on opiates, and paracetamol remains the same. The coagulation hemostasis, again important. We know that the surgery itself is leads to coagulopathy, because liver dysfunction will happen. But simultaneously, CA ovarian patients are also procoagulant. They will have a very high chances of thrombosis, DVTs, and subsequent pulmonary embolism. That's why early mobilization is the key, but simultaneously, moment the patient comes inside the theater, start the DVT prophylaxis from there in itself. So this means DVT pump needs to be